Hello everyone. Topic for today's discussion is sexual dysfunction in diabetes. Sexual dysfunctions are very common both in men and women with diabetes. However, the sexual dysfunctions are more common in men as compared to women, and among the men, erectile dysfunctions are very common if they are having diabetes. Sexual health in diabetes is a key aspect in respect to diabetic care. However, the sexual dysfunction in diabetes is often overlooked. In studies, it is found that the sexual dysfunction in men with diabetes mainly focus on erectile dysfunction. However, there are many other sexual dysfunction apart from erectile dysfunction in men. In respect of women with diabetes, the less data is available on sexual dysfunction, and the reason behind is lack of standardized evaluation of sexual function in women and associated social taboos in the community. The sexual dysfunction and erectile dysfunctions are the topic to which the many people in the community hesitate and embarrass to talk. However, in respect of its magnitude, it is found that about 35 to 50% of men with diabetes they report erectile dysfunction, and as the age increases, the prevalence of the sexual dysfunction or erectile dysfunction also increases. The sexual dysfunction or erectile dysfunction are also considered as neglected complication of diabetes, and these are also known as silent complications due to above mentioned reasons. However, nowadays the advent of PD5 inhibitors have revolutionized the treatment of erectile dysfunction. These are the list of sexual dysfunction found in any patient with diabetes in men and women. In men, the listed sexual dysfunctions are erectile dysfunction, diminished sexual desire, anejaculation, and retrograde ejaculation. In women, the commonest listed sexual dysfunctions are diminished sexual desire, genital arousal disorder, disorders of orgasm, and sexual pain. Apart from these listed sexual dysfunctions in women, there are few other sexual dysfunctions which are found in any woman with diabetes. These sexual dysfunctions can be menstrual abnormalities, the polycystic ovarian disease, delayed psychological development in girls with diabetes has been noted, genitourinary infections, abnormalities in sexual responsiveness, sometimes there may be vaginal dryness, and dyspareunia can also be present. Dyspareunia is a condition when there is persistent or recurrent genital pain occurs, and this condition can be present just before, during, or after the sexual intercourse. Pregnancy is usually occasionally contraindicated in women with diabetes, and it is strictly contraindicated when the diabetes is associated with severe ischemic heart disease, the advanced untreated proliferative retinopathy, renal insufficiency, severe gastroparesis is present, and when the HbA1c level is more than 10%. What are the significance of these sexual dysfunctions? If the sexual dysfunctions are present in any patient with diabetes, so this is a predictor of potent cardiovascular diseases. Apart from that, the diabetes in such patients can also have some other serious complications of diabetes. It is also found that these sexual dysfunctions are very prominent and they are more refractory for treatment. There are various influencing factors in sexual dysfunction. The first one is age. As the age increases, the chances or prevalence of sexual dysfunction also increases. Both men and women are affected with sexual dysfunction, as we have already discussed in previous slide. However, the chances of getting sexual dysfunction of men is higher as compared to women. It is seen that the men with diabetes have 3 times more frequency or chances to have sexual dysfunction as compared to the men without diabetes. It is also seen that if in any man erectile dysfunctions are already present, then it's an early sign of having neurological sequelae in that diabetic patient in the later of his life. Now let's discuss about the mechanism of penile erection. The penile erection is the result of a complex interaction of psychological, neural, vascular and endocrine factors. During the erection, there is dilatation of helicine and cavernous artery. Here you can see in the center there is one artery known as cavernous artery. On periphery, various small helicine arteries are present, and during erection, this helicine and cavernous arterioles are filled up with blood and they dilate. Similarly, there is compression of the venules which are surrounding these arterioles, and all these two changes takes place against the rigid tunica albuginea. Here in white color you can see tunica albuginea. This tunica albuginea is white dense color of fibrous tissue which cover the penile erectile bodies. The main mechanism behind the penile erection is smooth muscle relaxation, which is mediated by nitric oxide. This nitric oxide can be generated from the parasympathetic neuronal endings, which are important for the initiation of the erection. Apart from that, the nitric oxide can also be generated from the vascular endothelium. The nitric oxide works by relaxing inner muscles of the blood vessels and enable blood to flow into the penis of the man, and ultimately by relaxing these smooth muscles of the blood vessels, the erection process started. Now let's discuss about the pathophysiology of erectile dysfunction in diabetes. Sexual dysfunction in any individual with diabetes is an interplay of defects in the various systems of the body. This system include neuronal, the vascular, hormonal and metabolic systems. In diabetes, we know that due to the complication there is a condition arises which is known as autonomic neuropathy, as well as the endothelial dysfunction is also common due to diabetes. Due to both of these conditions, there is impaired generation of the nitric oxide, and this impaired generation of nitric oxide impairs the smooth muscle relaxation, as we have already discussed in previous slide how the nitric oxide causes the smooth muscle relaxation, and due to this impaired smooth muscle relaxation there is erectile dysfunction in any individual with diabetes. As we know, in diabetes the end organs are damaged due to the uncontrolled level of blood glucose in the body, and apart from that, psychological stress is also very common in any patient with diabetes. There are various systems which are involved for the mechanism of erectile dysfunction in any individual with diabetes, and these systems are neurological, metabolic, hormonal and vascular. Now let's discuss how the neurological system is involved in causation of erectile dysfunction. In normal mechanism, the autonomic and somatic nerves are responsible for the process of ejection and ejaculation of the semen. However, in a case of diabetes, whenever the complication of diabetic neuropathy develops, in this condition the bladder neck fails to close, and this generates a condition known as retrograde ejaculation. This Retrograde ejaculation is a medical condition in which the semen travels backward toward the bladder instead of traveling forward and coming out of the penis during the orgasm, and this ultimately leads to development of erectile dysfunction. Coming to the metabolic system involvement in erectile dysfunction, as we know that in normal mechanism of erection, nitric oxide production is the main source for the erection, but in case of diabetes there are production of glycosylated end products in diabetes which will lead to decreased production of the nitric oxide, and due to this decreased production of nitric oxide, this will lead to cavernosal smooth muscles to get relaxed, and which will lead to development of erectile dysfunction. Now discussing to the vascular system involvement in erectile dysfunction, as we know that diabetes is prone for development of atherosclerosis. This atherosclerosis will lead to vascular insufficiency mainly in the genital organs like introitus, vagina, labia minora, clitoris in women, as well as penis in the men, and this will affect the female sexual organs as well as the male sexual organs to function normally, and this will lead to development of genital arousal disorders in men as well as in the women. Now coming to the hormonal system involvement in development of erectile dysfunction, as we know that diabetes leads to development of condition hypogonadism, and in hypogonadism there is reduced testosterone hormone production. This reduced testosterone hormone production will lead to reduced sexual desire, as well as this will generate the condition of erectile dysfunction. Apart from this reduced testosterone has some metabolic dysfunction as well. These are reduced bone mineral density, increased fatigue, and development of depression in the male as well as in the females. This slide shows all the pathophysiologies which we have discussed in a single table with headings: system involved, the mechanism, the conditions which predispose for erectile dysfunction, and the end organs which are affected. There are few contributory factors which will either generate the condition of erectile dysfunction or which can aggravate this erectile dysfunction in a patient with diabetes. These are presence of hypertension, use of tobacco, the concomitant use of medications like beta blockers, thiazide, few diuretics, and tricyclic antidepressant. Some psychogenic factors can also lead to erectile dysfunction, and lastly the alcohol abuse can also lead to erectile dysfunction. Now discussing to the investigations to be performed in case of sexual dysfunction. In this we should thoroughly examine the genitalia as well as the cardiovascular system and peripheral nervous system for its functioning. Apart from that, some other investigations are also required like level of testosterone, the level of prolactin, as well as by the level of thyroxine hormone by doing the thyroid function test. Apart from that, some other special investigations should also be carried out, which are formal psychological assessment of the individual, the autonomic function test by some activities which are designed to stimulate the autonomic nervous system to produce changes in the blood pressure, the heart rate, breathing, and sweating in controlled settings. The next test is penile Doppler study with papaverine. This method is the method in which the Doppler ultrasonography examination is combined with an intracavernosal injection of some vasoactive agents which can be papaverine, phentolamine, or prostaglandin even. In this we can assess the any abnormalities, any anatomical abnormalities in penis, as well as we can also assess the uh, hemodynamics of the penis and any other abnormalities associated with the hemodynamics of the penis. Now let's discuss how the screening for sexual dysfunction in men can be performed. In men, serum testosterone level should be measured. It should be measured between 8 am to 11 am. If the level of testosterone comes low, then this should be confirmed by the repeat testing. Apart from that, few central causes of hypogonadism should be ruled out, and it can be done by the measurement of the level of FSH, follicular stimulating hormone, LH, the luteinizing hormone, and the measurement of level of prolactin. Coming to the screening process for sexual dysfunction in women. This screening process in women consists of detailed medical and sexual history, and as well as the physical examination of the woman. In detailed medical history, we should check for any comorbid illnesses in the woman, the current treatment status of the diabetes, and about the menstrual history. Any abnormalities in menstruation should be ruled out. In sexual history, we should check for the interpersonal status with spouse, history of sexuality, any sexual abuse or any previous sexual encounters in the past, as well as we should also check about the social and religious belief about the sexuality. Coming to the physical examination in the process of screening in women. In this, we should check for the signs of any pelvic inflammatory diseases. We should try to identify any signs of female genital mutilation. We should also detect the condition of hyperandrogenism in case of women. This assessment of hyperandrogenism can be done by the assessment of few hormones in the women. This include the measurement the level of serum testosterone, estradiol, the follicular stimulating hormone, luteinizing hormone, and also by the checking the level of prolactin. Now let's discuss how the sexual dysfunction can be diagnosed in men as well as women with diabetes. Sexual dysfunction in men with diabetes can be diagnosed when the total testosterone level comes less than 320 nanogram per deciliter and the free testosterone level comes to less than 64 picogram per ml. The condition of sexual dysfunction in women with diabetes can be diagnosed with the presence of any pelvic inflammatory disease such as vaginitis, presence of autonomic neuropathy, or if urinary tract infection is present. We should also check for the female genital mutilation for the diagnosis. Diagnosis can be confirmed by the checking the estrogen level if it is low, and apart from that we should also assess about the hyperandrogenism about which we have already discussed in previous slide. Now let's discuss about the treatment options for the erectile dysfunction. The first one is by using general measures. It includes improvement in the diabetic control. Second one is weight management. Third one is regular exercise. Another is reduced alcohol intake, as we have found that alcohol abuse is also related with the erectile dysfunction. Cessation of smoking. Apart from that, we should withdraw the causative drugs of erectile dysfunction, which includes thiazides, tricyclic antidepressant, beta blockers, etc. Apart from that, we should correct the endocrine problems in which the individuals are affected with erectile dysfunction, and we should try to correct such endocrine problems. Coming to the drugs. In drugs, the most important drugs are PDE5 inhibitors, which includes sildenafil, tadalafil, vardenafil. Apart from that, intracorporeal vasoactive drugs injections are also useful. In this, patients are taught to inject a vasoactive agents into their corpora cavernosa. These vasoactive drugs or agents can be papaverine, phentolamine, etc. After the injection of these drugs in corpora cavernosa using a 27 or 30 gauge needle prior to planned intercourse, erection can be achieved after typically 15 minutes after the injection, and this lasts up to 45 to 90 minutes after the injection. Apart from this, there are some other drugs which are also effective, known as oral apomorphine. This apomorphine exerts its effect on the hypothalamic centers involved in the triggering of the erection cascade. It dissolves rapidly and result in erection in responders in approximately 20 minutes after the consumption of these drugs. Apart from that, there are few other counseling and discussion methods by which this erectile dysfunction can be treated. Among that is the informal discussion about the sex. Another method is sensate focusing. The sensate focusing is a combination of exposure therapy, and by using which we can improve the intimacy and communication between the sexual partners about the sex, and by this we can also reduce the anxiety which is associated with the sexual performance. The another method in this is knowledge about the formal sex and psychological therapy, and the last one method is reassurance of the individuals. Coming to the fourth class of treatment, which are known as vacuum tumescence devices and surgery, and main mechanism behind this method is by the correction of anatomical abnormalities associated with the erectile dysfunction. Implantation of the penile prosthesis can be another method of erectile dysfunction treatment. In this, these penile implants are placed inside the penis. These penile implants are the devices which are placed inside the penis, and it helps to get an erection by the man. Another method is by the arterial surgery, and the goal of this operation is to bypass the blocked arteries that cause erection problems. Correction of venous leakage by the vein ligation surgery can also be an important and popular method for the correction of this erectile dysfunction. Now let's discuss about the most important and most popular drugs used in a case of erectile dysfunctions. These drugs are phosphodiesterase 5 inhibitors. These PDE5 inhibitors are effective in producing satisfactory erection in about 60% of the diabetic patients who are having erectile dysfunction. The main mechanism of these drugs is by blocking the inactivation of the CGMP. So this CGMP gets activated and it ultimately leads to cavernosal smooth muscle relaxation, and ultimately it helps in erection of the penis. Examples of this class of drugs are sildenafil, tadalafil and vardenafil. These drugs are usually taken 1 hour before the planned sexual activity, and for these drugs the window of opportunity is around 4 hours. About the side effects of these drugs, the side effects commonly presented are headache, flushing and blurring of vision. This class of drugs are contraindicated in patients who are contraindicated for the nitrates, or in which the nitrates can't be given. Here in this diagram we can see how this phosphodiesterase 5 inhibitors works in process of erection. We can see here that this PDE5 inhibitors blocks the inactivation of this CGMP and makes it available so that it can cause the smooth muscle relaxation, and ultimately it will lead to penile erection. Here we can see the comparison of all these three drugs of the class PD5 inhibitors. Usually these drugs are taken 1 hour before the sexual intercourse, and for all these three drugs the mode of metabolism is also common, that is in liver. The another issue associated with diabetes is male hypogonadism. It is seen that the obesity and diabetes are the risk factor for development of this secondary hypogonadism. It is found that in 25% of men with type 2 diabetes have subnormal free testosterone level with inappropriately low level of LH and FSH level, which is known as hypogonadotropic hypogonadism, and in about 4% of men with type 2 diabetes have low testosterone with elevated level of FSH and LH. And it is also found that the low testosterone level is linked with the development of higher risk of cardiovascular diseases. It is seen that this male hypogonadism can be treated by testosterone replacement therapy, and this testosterone replacement can improve the insulin sensitivity as well as it can reduce the waist circumference. However, the effect on glycemic control and cardiovascular risk factor of this testosterone replacement therapy is inconsistent. It is also found that by using this testosterone replacement, libido can be improved, but it doesn't totally correct the erectile dysfunction. So in that condition we are required to concomitant use of PDE5 inhibitors for correction. Now let's discuss to the treatment of sexual dysfunction in women. So for different problems we require a different treatment approach in case of treatment of sexual dysfunction in women. For example, for genital and urinary tract infection we can use antibiotics. For mood disorders and depression we can use antidepressant drugs. For postmenopausal women the hormone replacement therapy is the best choice. In case of dryness and dyspareunia, that is painful sexual intercourse, it can be treated with using moisturizers and lubricants while doing the sexual intercourse. For hypoactive sexual disorders, phybonacerine class of drugs can be used, and for traumatic sexual experiences, counseling is the best method of treatment. We have come to the end of this video. We hope you have liked this video. Please like and share this video with others.